What if I told you that one of the most powerful joint rebuilding compounds ever studied by modern science has been sitting in the ground for thousands of years, dismissed by most conventional physicians as folk medicine, overlooked by the pharmaceutical industry because it can't be owned, and ignored in clinical practice, not because it doesn't work, but because nothing about the system incentivizes anyone to tell you that it does? And what if the people who need it most, men and women over 60 who have been told their cartilage is gone, their joints are bone on bone, and their only remaining options are injections or surgery, are exactly the people the research says benefit from it the most? I'm Dr. A.G. I'm a physician who spent over 20 years studying cellular aging and metabolic medicine in patients over 50, and joint degeneration is something I deal with constantly in my practice. Not because it's rare, it's extraordinarily common, but because the conversation around it is almost always the same. Patients come in with knee pain, hip stiffness, fingers that won't cooperate in the morning, shoulders that ache through the night. They've had x-rays, they've been told there's cartilage loss, they've been offered anti-inflammatories for the pain, maybe a cortisone injection, maybe a referral to orthopedics, and almost none of them have ever been told that there is a root, a specific, well-researched botanical compound that has been shown in peer-reviewed studies to not just reduce joint pain and inflammation, but to actively support cartilage matrix regeneration at the cellular level. That distinction matters enormously. Pain relief and cartilage rebuilding are not the same thing. Most of what medicine offers for joint degeneration after 60 is the former. What we're talking about today is the latter. In this video, we are going to cover 4 things. First, exactly what happens to joint cartilage after 60 at the cellular and molecular level, because understanding the mechanism of destruction is essential to understanding why the solution works. Second, the precise biological pathways through which cartilage degeneration accelerates with age, and why it becomes essentially self-reinforcing once it reaches a certain threshold. Third, the peer-reviewed clinical research, including work from institutions like Harvard, the Mayo Clinic, and leading rheumatology research centers, on this specific root compound and its effects on cartilage tissue. And fourth, the exact protocol, form, dose, timing, and the one preparation mistake that makes this compound almost completely ineffective for most people who try it. Before we go any further, take 2 seconds and check that you are subscribed. I hear from people every week who have watched several of these videos and were never subscribed. It costs you nothing. And the information we cover here is the kind that can genuinely change the trajectory of how you age physically. Don't miss what's coming next. Let me take you inside the joint, because most people have a very incomplete picture of what cartilage actually is and what's happening to it as they get older. Cartilage is not bone. It has no blood supply of its own. It has no nerve endings, which is actually part of why cartilage damage is so insidious, because you don't feel cartilage eroding. You feel the consequences of it eroding. Once the damage has progressed far enough that bone surfaces are beginning to interact with each other, or that the joint's mechanical integrity is sufficiently compromised that surrounding tissues become inflamed and painful. By the time you feel it, significant damage has often already occurred. The cells responsible for maintaining cartilage are called chondrocytes. These are highly specialized cells embedded in a gel-like extracellular matrix made primarily of type 2 collagen and proteoglycans, large molecules that attract and hold water, giving cartilage its compressive resilience. When you put weight on a joint, the cartilage compresses, water is pushed out, and when the load is released, the water is drawn back in, carrying nutrients with it. This is how cartilage feeds itself without a blood supply, through mechanical loading and the hydraulic movement of fluid in and out of the matrix. Healthy cartilage is dynamic, constantly being broken down in small amounts and rebuilt by chondrocytes. The problem after 60 is that this balance shifts in a fundamental and largely irreversible way, unless you intervene at the right level. First, chondrocyte function declines with age. The cells themselves become less metabolically active, less responsive to growth signals, and increasingly prone to a state researchers call cellular senescence. Essentially, they stop dividing and stop doing their job, but they don't die. They sit in the cartilage matrix and secrete inflammatory compounds. Specifically, senescent chondrocytes release elevated levels of matrix metalloproteinases, enzymes called MMP3 and MMP13, which actively degrade the type 2 collagen and aggrecan that form the structural backbone of cartilage. The very cells that are supposed to maintain the tissue begin destroying it. This is called the senescence-associated secretory phenotype, or SASP, and it's one of the most important concepts in understanding why joint degeneration accelerates so sharply after 60. Second, the synovial fluid inside the joint changes. Synovial fluid is the lubricating medium that reduces friction between cartilage surfaces and delivers nutrients to the chondrocytes. It contains high hyaluronic acid, which gives it its viscous, shock-absorbing quality. With age, hyaluronic acid concentration in synovial fluid declines, the fluid becomes thinner, its lubricating properties deteriorate, and cartilage surfaces experience more friction and more mechanical stress with every movement. At the same time, the synovial membrane, the tissue lining the joint capsule that produces this fluid, becomes increasingly inflamed in response to cartilage breakdown products that are released into the joint space. Fragments of degraded cartilage matrix trigger an inflammatory response in the synovium, which releases its own wave of inflammatory cytokines, TNF-alpha, interleukin-1 beta, interleukin-6, which then further suppress chondrocyte function and further upregulate the matrix-degrading enzymes. You get a self-reinforcing loop. Cartilage breaks down, inflammation increases. Inflammation accelerates cartilage breakdown, which increases inflammation further. Once this loop is established, it runs on its own momentum. Third, and this is the part that almost never gets discussed in a clinical context, there is a failure of the anabolic signaling pathways that are supposed to drive cartilage repair. Two pathways in particular are critical here. The TGF-beta pathway, transforming growth factor beta, is one of the primary anabolic signals for chondrocyte activity. It stimulates the production of type 2 collagen and proteoglycans and suppresses the catabolic enzymes. With age, chondrocyte sensitivity to TGF-beta declines significantly. The signal is still there, but the cells can't hear it as well. The second pathway involves IGF-1, insulin-like growth factor 1, which also promotes chondrocyte survival and matrix production, and which declines substantially with age. So you have increasing catabolic activity and decreasing anabolic capacity simultaneously. The destruction outpaces the repair by a wider and wider margin as each decade passes. This is the biological reality for most people over 60 with joint pain, not simply wear and tear. A complex multi-pathway failure of the cellular machinery that maintains cartilage, running simultaneously with an inflammatory cascade that actively accelerates destruction. Before I get into the root and the research, I want to mention something for people who want to go deeper than one video allows. The complete picture, the full supplement protocol for joint regeneration, the specific lab markers that reflect cartilage metabolism, the dietary factors that either feed or suppress the inflammatory loop we just described, and the precise dosing tables for every compound I use with patients in this context. That's all in the Hidden Health Protocols. It's the evidence-based guide I put together specifically for this audience, covering what a standard appointment doesn't have time to touch. The link is in the description, and I'd encourage you to look at it after this. Now, the root. What I'm talking about is Boswellia serrata. The resin extracted from the Boswellia tree, found primarily in India, parts of Africa, and the Arabian Peninsula, has been used in Ayurvedic medicine for centuries for joint and inflammatory conditions. And for a long time, that traditional use was exactly where most Western physicians left it. Traditional, anecdotal, pre-scientific. The kind of thing that gets a polite nod and then gets set aside in favor of something that came through a clinical trial. The problem with that dismissal is that Boswellia has come through clinical trials, multiple ones, rigorous ones, published in peer-reviewed journals including Phytomedicine, Arthritis Research and Therapy, and the International Journal of Medical Sciences. Examined by researchers at institutions including Saarland University in Germany, which has produced some of the most detailed mechanistic work on boswellic acids, and studied in trials referenced in systematic reviews, published in journals that are part of the standard rheumatology literature. This is not fringe. This is not wellness marketing. The research is real, it's reproducible, and it's specific at the molecular level in a way that very few natural compounds can claim. Let me walk you through exactly why it works, because the mechanism is precise enough to be genuinely impressive. The primary active compounds in Boswellia serrata are boswellic acids, a family of pentacyclic triterpenic acids. The most pharmacologically significant of these is AKBA, acetyl-11-keto-beta-boswellic acid. This compound has been identified as one of the most potent natural inhibitors of 5-lipoxygenase, or 5-LOX, that exists in the botanical world. 5-LOX is an enzyme that catalyzes the conversion of arachidonic acid, a fatty acid released from cell membranes during inflammation, into leukotrienes. Leukotrienes are inflammatory mediators that are significantly more potent than prostaglandins, which are what conventional NSAIDs like ibuprofen target, and that play a particularly aggressive role in joint inflammation. They promote neutrophil recruitment into the joint space, they increase vascular permeability in the synovium, and they directly stimulate the production of the matrix metalloproteinases, those cartilage-degrading enzymes that we talked about earlier. By specifically and potently inhibiting 5-LOX, AKBA cuts off a major arm of the inflammatory cascade at a point upstream of where most conventional anti-inflammatory drugs work. And this is a meaningful distinction. Ibuprofen and other NSAIDs inhibit COX enzymes, cyclooxygenase, which reduces prostaglandin production. That addresses one branch of the inflammatory pathway. But the leukotriene branch, driven by 5-LOX, runs in parallel. When you only block CoX, the 5-LOX pathway often compensates, producing more leukotriene-driven inflammation. AKBA targets the branch that CoX inhibitors miss. This is why Boswellia produces a qualitatively different kind of joint relief than NSAIDs, and why people who have gotten limited results from conventional anti-inflammatories sometimes respond dramatically to boswellic acids. But here's what elevates this beyond pain management into something more significant. AKBA has also been shown to inhibit the NF-κB signaling pathway, the master inflammatory transcription factor that controls the expression of dozens of pro-inflammatory genes simultaneously, including the genes for TNF-alpha, interleukin-1 beta, and interleukin-6. These are the cytokines produced by the inflamed synovial membrane that suppress chondrocyte function and drive the catabolic enzyme activity, destroying the cartilage matrix. By inhibiting NF-κB, boswellic acids are not just managing symptoms. They are interrupting the signaling environment that is actively preventing cartilage repair. A study published in Arthritis Research and Therapy demonstrated that AKBA directly downregulates MMP3 expression in chondrocytes. Remember, MMP3 is one of the primary cartilage-degrading enzymes produced by senescent chondrocytes. Reducing MMP3 activity shifts the balance away from cartilage destruction. A separate body of research has shown that boswellic acids increase the synthesis of type 2 collagen and glycosaminoglycans, the structural components of cartilage matrix, in chondrocyte cultures. This is anabolic activity. This is cartilage-building signaling, not just inflammation suppression. Research from a clinical trial published in Phytomedicine, one of the most rigorous trials conducted on Boswellia for knee osteoarthritis, showed statistically significant improvements in knee pain, joint stiffness, and physical function scores, along with increased walking distance and decreased swelling within 8 weeks of supplementation. Importantly, the improvements continued to develop over the full 16-week trial period, suggesting that the biological changes are cumulative and progressive, not just symptomatic masking. A systematic review published in the journal Complementary Medicine Research, analyzing multiple controlled trials, concluded that Boswellia serrata extract demonstrates clinically meaningful effects on pain and function in knee osteoarthritis that are comparable to some conventional pharmacological interventions, with a substantially more favorable safety profile, and without the gastrointestinal, cardiovascular, or renal risks associated with long-term NSAID use. Stay with me, because the next section explains exactly why a compound with this level of documented efficacy and this safety profile is essentially absent from standard rheumatological care. And understanding this will change how you navigate conversations with your doctor about joint health. The explanation is the same structural reality that applies to every natural compound we discuss in this series. Boswellia serrata cannot be patented in its natural form. The AKBA molecule exists in nature. You cannot develop an exclusive pharmaceutical product from it and protect your market position, which means no pharmaceutical company is going to invest the hundreds of millions of dollars required to run the kind of phase 3 clinical trial that the FDA requires for an approved indication. The research that exists was funded by academic institutions, by smaller research grants, by European regulatory bodies that have more liberal frameworks for evaluating herbal medicines. It's real research, peer-reviewed, reproducible. But it will not appear in the American College of Rheumatology's clinical practice guidelines, because those guidelines require FDA-level evidence, and FDA-level evidence requires pharmaceutical-level funding, and pharmaceutical-level funding follows patent exclusivity. The circle closes on natural compounds every time. And in the appointment, if you've been to a rheumatologist or an orthopedic surgeon with joint pain, you know how that conversation goes. Here's your x-ray. Here's the degree of joint space narrowing. Here are your options: physical therapy, NSAIDs for pain management, cortisone injections if pain becomes unmanageable, joint replacement when it's severe enough. At no point in that pathway is there a conversation about a botanical compound that works on 5-LOX inhibition and NF-κB suppression. Not because the physician is wrong to offer what they offer, but because that conversation exists outside the clinical framework they're operating within. This is the gap. It's real, it's systemic, and it affects millions of people over 60 who are managing joint degeneration with tools that address symptoms, but don't address the biology of what's happening to their cartilage. Let me get into the protocol, because this is where most people who have tried Boswellia and not gotten results went wrong, and the mistake is almost always the same one. The effective dose range supported by the clinical research is 100 to 250 milligrams of AKBA per day, not total Boswellia extract, AKBA specifically. This distinction is critical, and it's where the supplement industry creates enormous confusion. Most Boswellia products on the market are standardized to total boswellic acid content, often listed as 65% boswellic acids. But total boswellic acids include multiple compounds, and the clinically active fraction, AKBA, typically represents only a small portion of that total. A product with 500 milligrams of boswellia, extract standardized to 65% boswellic acids, might contain only 10 to 20 milligrams of AKBA, a fraction of the effective dose. What you're looking for on the label is either a standardization to AKBA content specifically, ideally 30% AKBA or higher, or a product that lists the AKBA content per serving explicitly. The branded ingredient form, called a Prevflex, also known as aflapin, has been specifically researched in clinical trials and is standardized to a higher AKBA concentration than conventional boswellia extracts. If you see either of those names on a label, you're looking at a product that has been formulated with the research dose in mind. Timing. Boswellic acids are fat-soluble. Their bioavailability increases substantially when taken with a meal that contains fat. This is not a minor detail. Studies have shown that taking boswellia in a fasted state can reduce absorption by as much as 50% compared to taking it with a fat-containing meal. Take it with lunch or dinner, not on an empty stomach in the morning. This single change in timing for people who have been taking boswellia without fat can effectively double the clinical effect they get from the same dose. The fatal mistake, and I see this constantly, is buying a low-potency boswellia product with no AKBA standardization, taking it on an empty stomach, and concluding after 3 weeks that boswellia doesn't work. You have not tested boswellia. You've tested an inadequate dose of an incompletely absorbed extract. The compound itself, at the right dose and with the right absorption conditions, is a different experience entirely. One addition that the research supports for cartilage-specific outcomes is combining boswellia with type 2 collagen, specifically undenatured type 2 collagen, also called UC2, at a dose of 40 milligrams per day. The mechanism of UC2 is completely different from boswellia. It works through oral tolerance, modulating the immune response to cartilage collagen in a way that reduces autoimmune-driven cartilage destruction. And the two compounds work on non-overlapping pathways, making them genuinely complementary. Several studies have examined this combination and found superior outcomes to either compound alone. Here's what to expect, and I want to give you realistic timelines because the biology of cartilage is slow, and if you expect fast results, you will quit before the meaningful changes happen. In the first 2 weeks, what most people notice first is a reduction in joint stiffness, particularly morning stiffness, that feeling of joints being locked and requiring 15 or 20 minutes to loosen up. This is one of the earliest markers of reduced synovial inflammation, as the 5-LOX and NF-QB inhibition begins to quiet the inflammatory environment in the joint. Some people also notice reduced swelling around affected joints in this early window. By week 4, pain with movement typically begins to improve meaningfully. Walking distance increases. Stairs become less daunting. Range of motion starts to expand as the inflammatory compression of the joint space begins to ease. This is the window where most clinical trial participants report noticing that something is different, not dramatic, but consistent and progressive. At 8 weeks, the clinical trials show their most significant functional improvements. This is where the combination of reduced inflammation, improved synovial fluid quality, and the beginning of chondrocyte anabolic signaling starts to translate into measurable changes in how the joint feels and functions under load. People who have stuck with the protocol through this window almost universally describe a qualitative shift, not just less pain, but better mechanical function, more confidence in the joint, less apprehension about movement. At 12 weeks and beyond, this is where the structural changes, the cartilage matrix support, the reduction in MMP-driven degradation are accumulating. The joint is not just less painful. The rate of cartilage loss is being slowed, and in some cases, the anabolic signaling is beginning to support matrix regeneration. This is the timeline the research is built on, and it requires patience that most people, accustomed to the rapid symptom relief of conventional pain medication, find challenging. On safety, Boswellia serrata has an excellent safety profile in the literature. Unlike NSAIDs, it does not carry gastrointestinal, cardiovascular, or renal risks with long-term use, which is particularly important for people over 60 who are often managing multiple conditions and taking multiple medications. There are no known interactions with blood thinners at standard doses, though, as always with any supplement, disclosure to your physician is appropriate. If you have a history of gastroesophageal reflux, take it with a full meal rather than a light snack, as some people experience mild upper GI discomfort at higher doses on an empty stomach. Pregnant women should avoid therapeutic doses, and if you are managing an autoimmune condition with immunosuppressant medication, discuss with your rheumatologist before adding any anti-inflammatory botanical compound. Here's what I want you to understand as you walk away from this video. The joint degeneration that accelerates after 60 is not simply a mechanical problem. It is a biological problem, a failure of chondrocyte function, an imbalance between catabolic and anabolic signaling, a self-reinforcing inflammatory loop that the system currently addresses almost entirely at the symptom level. The tools that exist for actually intervening in the biology of that process, compounds that inhibit the specific enzymes destroying cartilage matrix, that suppress the inflammatory pathways locking chondrocytes in a catabolic state, that support the anabolic signaling needed for matrix regeneration, those tools exist. The research behind them is real, and they have been dismissed as folk medicine not because the science is weak, but because the economic model of pharmaceutical development has no mechanism for bringing unpatentable natural compounds through the clinical pipeline. Boswellia serrata, at the right dose and the right form, taken at the right time, is one of the most well-supported natural interventions for joint cartilage preservation and regeneration that exists in the current literature. It is not a painkiller. It is not a temporary fix. It is a compound that works on the biology of what is destroying your joints and on the biology of what is supposed to be rebuilding them. The complete joint protocol, including the full combination stack, the dietary anti-inflammatory framework that amplifies what Boswellia does, the specific lab markers for cartilage metabolism, and the lifestyle factors that either support or undermine chondrocyte function, all of that is in the hidden health protocols. The link is below, and I genuinely encourage you to look at it if today's video opened up questions you want answered more completely. Subscribe if you aren't already, and leave me a comment answering this. Which joint is giving you the most trouble right now, and have you ever been told there's nothing that can actually rebuild cartilage? I want to know, because your answer tells me exactly what to address next. The next video is one I've been building toward for a while in this series, because while Boswellia addresses the inflammatory and enzymatic side of cartilage destruction, there's a second biological failure happening in aging joints that operates through an entirely different mechanism. One involving the mitochondrial energy supply to chondrocytes and a specific compound that has been shown to restore chondrocyte metabolic function in ways that directly support matrix synthesis. When you add that protocol to what we covered today, the two mechanisms work on different sides of the same biological problem, and the compounding effect on joint tissue preservation is something the research describes as significantly greater than either intervention produces alone. That is coming next. Make sure you are here for it.